Okay, I'll go ahead and get started with the introduction. Thrilled to have you all joining us for the IRP Thursday seminar series. Today we have a speaker I'm very excited to hear from. We have Jim Sullivan, who is a professor of economics, a founder and co-director of the Lab for Economic Opportunity at Notre Dame. Jim has been studying effective policy for reducing poverty, incredible work related to poverty and consumption. And I'm really thrilled to have him here with us today, sharing some of his work on an RCT related to helping reduce poverty. Jim has agreed to take questions. He's a true blood economist and likes to be interrupted. So we'll ask that you place your questions of clarification and or substantive issues in the chat function. And if it turns into, or if it seems like a question that is better handled by unmuting you, I can do that. So please use the chat question or the chat function for questions. And with that, Jim, excited to hear your work, and I'll turn it over to you.
Great. Thank you, Catherine. I am going to share my screen so that we can look at some slides. And I'm assuming you all can see the slides now. So this is a new project that we just randomized controlled trial evaluation of a really interesting project we just finished up, and it's a great time to get feedback. I suppose this is the point in the seminar when I say I love seeing your beautiful campus in the fall and all that. I'm sorry I can't say that, but as I was saying with Jeff earlier, maybe I'll get a chance to get down there, or at least to Lambeau Field sometime soon. This project is joint work with Bill Evans, who is a co-founder of LEO with me, as well as Shauna Kolka, who was a research associate here at LEO, and Patrick Turner, who's a research faculty member here at LEO. So I've just said LEO a bunch of times. I often get people who at this point ask me, who is LEO? So I do want to talk a little bit about what do I mean by LEO? And so LEO is the Wilson Sheehan Lab for Economic Opportunities. I'm just going to have a quick plug on LEO because this is really the ideal audience to do so. Many of you have shared interests with the work of LEO, and if this is something that you think you might be interested in getting involved in, we're always looking to get external researchers involved in our work. So what is it that we do? So we're a research center that really matches researchers with local nonprofits, cities, and counties to help build research designs into either existing or developing programs that are designed to improve outcomes for vulnerable populations. Oftentimes this means we're helping nonprofits, cities, or counties launch randomized controlled trials, but we're not randomistas in the purest sense. We also do natural experiments and use historical data to help understand or to provide greater understanding on the impact of the work that they're doing. And the idea is you generate evidence on the impact of this work. That evidence is really the catalyst for scaling that work up at the local level, demonstrating that it's replicable, and informing providers about which programs that they should be launching in their own communities that have been proven to be successful. Also informing policymakers and funders about how to allocate scarce resources. We are approaching 75 projects now, either active or completed, all across the country, and we do work in education, criminal justice, health, self-sufficiency, refugee services, a number of different areas where we see a lot of involvement by cities, counties, and nonprofits in terms with the goal of improving outcomes for the most disadvantaged. So today's project is one of an example of a LEO project, and it is a randomized controlled trial. And I'm going to start by kind of covering the issue here that this project aims to address, and before I tell you what the intervention is in particular. So the issue, kind of maybe putting it too simply, is that poverty is complicated. And I don't think I'm saying anything revolutionary there. I think there's broad consensus that is the case. And yet it doesn't seem like a lot of interventions are designed with that in mind. So let me kind of give you a sense of what I mean. I'm going to do so by a completely hypothetical example. I'm going to introduce you to a woman named Rosa, who's a single mom from Dallas, Texas, who dropped out of high school, has 3 young kids, and because of the not having a high school degree, a lack of marketable skills, she relies on government transfers as her primary source of income. It's been particularly hard for her to have a job because there isn't great public transportation in Dallas, and her car is very unreliable, breaks down a lot. It makes it hard for her to maintain stable employment. And so given Rosa's situation, it's interesting to think about what could we do to move Rosa out of poverty. And you know, as you can see, Rosa's situation is a bit complicated. What might we do to move Rosa out of poverty? Well, first we might help her acquire an employable skill, and you know, a skill for which there is high demand in the local labor market. But it's not just as simple as let's get Rosa a job, right? Because there's also this issue of she has 3 young kids. How do we find quality daycare, and how do we do so in a way that's affordable for Rosa? You know, Rosa's now juggling a lot of different things with kids and work, and so how does she manage her time and address these transportation needs? And if that's not complicated enough, we could add a few other layers of complication. Say Rosa's English is not her first language, which might limit her job prospects to some degree. One of her children has a disability, so she has to focus a lot of her effort, time, and resources on addressing that issue. She has a parent with healthcare needs, and she experienced trauma in childhood, and that has had lifelong implications, right? So this seems like a very idiosyncratic situation, and it is very stylized, but I think the point here is that Rosa's situation certainly is complicated, and the fact that it's complicated is not unique to Rosa. This is something that many, if not most, in poverty are dealing with. And then the natural question becomes, well, what do we do about that? And that is kind of the motivation behind the intervention that I'm going to talk to you about today, which is called the Padua program. And Catholic Charities Fort Worth is they're the nonprofit that designed this program, and they really did so with Rosa in mind. They are one of the largest private providers of services to the poor in the Dallas-Fort Worth area, and they serve upwards of 40,000 clients a year. And they recognized that they provide a lot of services like emergency financial assistance, helping people pay rent and utilities, and they were recognizing repeat customers. And they started to ask this question, well, what can we do to address the fact that simple solutions are not going to move these people out of poverty? Is there something more comprehensive that could have a sustained effect? And so let me talk through a little bit about what the program that they spent several years designing and working with us to evaluate as part of a randomized controlled trial. So the first step kind of thing worth noting about Padua is it starts by identifying strengths and obstacles for each individual. So it's very individualized in its nature. So for example, you might think in the case of Rosa that identify that Rose is actually a pretty good people person, and she understands both English and Spanish, and so maybe there's a career that could match those skill sets. So they try to lay out an individualized service plan that addresses what Rosa's strengths are, and then identify what are going to be the obstacles for her following through with that service plan. And so in this case, they might find a job that there's a high demand. Say she's a good people person, and there's demand for phlebotomists in the area. We're going to put her through a certificate training program to be able to get that job, which would be both stable and have reasonably high wages. Once they lay out that plan, which is constructed in conjunction with the client themselves, they kind of agree on that plan, and then the rest of the intervention is designed to help follow through with that plan in their journey out of poverty. Now, a key component of that is this active case management, right? So they have small case management teams where a case manager, who usually has a master's in social work or similar qualifications, and a case aide that has a bachelor's degree, serve a caseload of 16 to 24 families and work with them to follow through on their plan. So what does that mean to provide case management? This is coordinating services. So there are a number of different services in the community that individuals don't take up or know about. So they help refer them to these other services. But importantly, they also provide coaching and mentoring. So they help them navigate obstacles as they arise. They help them, they provide emotional support and guidance and advice as they start to navigate the complexity of poverty and a path out of it. I'll give you a few more examples in a minute. The case management team also has access to targeted financial assistance, which means that, if Rosa's car breaks down, they can use financial assistance to address that short-term economic shock, so that she doesn't lose her job as a result of that particular issue. So it's used to address obstacles that might arise in the path out of poverty. There isn't a fixed date for how long PADUA services are provided for candidates, but or for clients, but you could roughly think about it as covering about 2 years. In terms of thinking about who is served by this program, they've defined the eligibility. Those between, really the focus was individuals in their community that were willing and able to work. And so they focused on those between 18 and 55. They were low income, which they define as it's about 100 below 180% of the poverty line, although most have much lower income than that. Tarrant County is the Fort Worth area, and then the family has to have at least one adult who is willing and able to work. So this is really an intervention that is designed first and foremost to improve labor market outcomes, but is very multidimensional. So there's other outcomes that we will look at. So the primary goal is to move them out of poverty. What does that mean? They don't just rely on the official definition. They take kind of a much more comprehensive approach to poverty here. And this is the way Catholic Charities defined what the goals of the program were. So a living wage was essentially a wage that gets you above 108% of the poverty line. Sufficient savings meant that they wanted these families to have enough savings to cover 3 months of income. They would have manageable debt. This is one of those things where they wanted everybody to be debt-free, and we explained to them that debt isn't always bad. So they changed it to manageable debt. And some independence from government programs, which the key there is, moving to self-sufficiency. The idea is that in order for a comprehensive program like this to be effective or scalable, you're really going to need to have some cost savings somewhere. So reduction in government programs.
Jim, can I interrupt with 2 questions?
Actually. Sure. Mm-hmm.
One from Liz Duffy. She wants to know how the program is funded. It sounds like the caseloads are low and highly qualified staffing. So it sounds really great, but potentially very expensive. That's from Liz. And from me, could you talk a little bit more about what it means to have an adult who is ready and willing to work? So just thinking back to your example of Rosa, which, she's willing to work, but is she ready in terms of skills? So I'm just wondering if you had a way of operationalizing ready to work, or if it was just more of a sentiment that someone says they were willing to work.
Yes, so great. So the first question on funding, yes, it is a very expensive program. I'll talk a little bit about cost benefit at the end of the talk. But in terms of, it is privately funded through local foundations right now. And this kind of fits the model that Leo often works in, which is that we work with programs that are locally funded. We generate the evidence on the impact. And for those programs that are shown to move the needle enough to really justify the investment, the evidence really helps the program scale and replicate. and seek additional funding. And additional funding could be, national foundations. Ultimately, we would like this kind of evidence to drive policy decisions so that there's support at a much larger level for those kinds of programs. But the expensive nature of the program is clearly important considering the scalability. On the what does it mean to be is really, do you have somebody that is physically able to work? So that that if there were disabilities or other permanent barriers to employment, that would prevent them from being eligible. A non-disabled example would be that some of them don't have legal status, although the agency does have a legal aid component that helps people get legal status. But if they don't feel like legal status is going to be attainable, then that might be a barrier. The willingness is nebulous, right? So they really get that at, are you interested in participating in a program where the ultimate goal is to get you to work, right? And so if they don't share that interest, then they would not consent to be really part of the program. So that's more how that's implemented. Great. Well, please interrupt as questions arise, or if you want to follow up on those even. So it has been, given the complicated nature of poverty and this intervention, it's been hard to explain what exactly does it mean. And so one of the more effective ways, I think, to communicate what's happening with Padua in terms of the services it provides is to just give you some real world examples. So the agency has collected detailed information about its clients and the problems that they have and the services they receive. And they've provided anonymized vignettes for us, or information for us, and we've constructed some vignettes. And I think this might be helpful for giving you a sense of how this program works. So let me introduce you to Claudia. So Claudia is a married mother of two. Her husband is a drug addict, but she's really the sole provider of a household of 7, because she, in addition to her kids, she takes care of her husband, parents, and a sibling that's living with her. She's employed, but she cannot afford the payments on a large house for these 7 people. She basically has too much of a real estate commitment, given her income right now. And on top of that, she has large credit card debt. She's on the brink of bankruptcy, and the stress is really holding her back, but in particular, preventing her from being particularly effective at work. So given that situation, what does Padua do? So Padua identified the key problems and the barriers for her path to self-sufficiency. And the first thing they identified is we need to get a more stable housing situation. And so they Claudia moved out with the help of her case manager out of the home with their kids. They found a smaller home that was much, much more affordable. She was put on a budget. And this is a common theme that we see is that the case managers work with the clients to have a budget to avoid accruing all of these debts. And the idea was to get her reduce her credit card debt and reduce dependence on payday loans. And they established a savings plan so she could start savings. She was successful at doing that, and within 2 years had received a promotion that put her above the poverty line as they had specified it. I'm going to introduce you to K2, another success story. This is by no means presented as evidence of the effectiveness of the program, but more just how the program works when it works effectively. So I'll give you the RCT evidence to determine whether or not it actually has impact. So Kay, another example, she's a stay-at-home mom of 2. She has a high school degree. Her husband can't work because he's undocumented. They're below the federal poverty line. Kay wanted to work to assist the family, but she doesn't have the skills necessary to do that. She tried to go to community college and dropped out. That didn't work out, and she really is quite intimidated about the idea of going back to community college. But working with a high school degree in her community has proven quite challenging. So in this case, the case manager worked directly with Kay to get it, rather than going to community college, they identified a medical assistant program that that where there was clear demand for people in this area, and was a program that they had agreed was something that K could handle and was well prepared for. There was the tuition barrier, and so this is where that emergency financial assistance component came in play. So they helped pay for this. This is kind of more as a referral. They found a charity that was willing to help her out with that. They got the family on a budget. Kay now has this job, and family income is well above at least the federal poverty line, if not the higher cutoff that the Catholic Charities Fort Worth has designated. So the general idea with these, and we have many more. We share with some of them in the paper, but poverty is complicated. Therefore, the way to address the issue is going to be idiosyncratic and unique to each individual, and so suggests a multifaceted and individualized intervention, and that's what Padua provides. This isn't completely new. There have been other examples of this. There's very little research on this for a general population of those in poverty. Let me just highlight a couple of experiments that have been done. The Building Nebraska Families is a small experiment for a welfare to work population that was particularly hard to employ, all of them TANF recipients. And they provided, it wasn't so much a diagnostics first to identify a plan approach. It was more like, how do we give you life skills and some skills to manage stress in your life, and then try to improve your labor market outcomes, help you match you with employment, et cetera. And it was a small experiment. It was hard to get precise estimates here, but they did find some promising evidence on increases in employment, and they found particularly large effects for those that were specified as hard to employ. Year Up is another example more recently of an intervention. This one's really targeted towards developing life skills and job training for young adults in urban areas. And the case managers meet with these young adults on a regular basis. There's weekly stipends. There is a modest case management component to it. And that kind of, at least for young adults, that kind of intervention is shown to significantly increase both earnings and full-time employment. So there's some promising evidence out there, really never tested in kind of like a broader population of people who are facing economic challenges and interact with the social safety net at the local level. So let me talk to you about what the Padua research design looked like. And so the way Catholic Charities Fort Worth interacts with clients most frequently is that people reach out to them through their call center or come in through the doors seeking emergency financial assistance to help avoid evictions, so pay 1 month's rent or to pay their utilities. And so they interact with thousands of clients a year in this way. And they incorporated into the call center and the intake process a really light screen that was done automatically. You know, do you have an able-bodied worker in the household? Do you satisfy the residency and age requirements? And the income requirements. And then they screened, amongst those, they screened them for Padua. So they introduced the program to these individuals, asked if they would be interested, they further collected information to see if they were eligible. So that gets us to this. Once they did the further screens on eligibility, we got down to 1,000 clients over the course of 2 years. And then they actually asked them if they wanted to participate. And 60% said, no, thank you, this isn't for me. This sounds like, it's too much involvement, not exactly what I'm looking for. We had, over the course of 2 years, we had 427 that agreed to participate. And we randomly assigned, based on available slots, individuals into treatment and control. We did so over the course of 2 years. And so there's 2 cohorts that we enrolled into this process. This was a lot to meet the capacity constraints of the case management teams. So the first cohort started enrollment in the fall of 2015, and then we followed them up with surveys to collect data on outcomes 1 year later and 2 years later. And then in the summer and fall of 2016, we started to enroll the second cohort and followed them up 1 and 2 years later. And so the evidence that I'm going to present to you is mostly going to be from the 2-year follow-up from both of these cohorts.
Jim,
Yes.
another question for me. That sounds like a fairly high not take-up rate, right? Or a low take-up rate for those that were offered. What do you know about those who are not taking up, and why they may not be taking up?
Yeah, so we have limited information about the families that decide not to take up, but we do have all the information from their intake form. And so one thing that we looked at is, are they fundamentally different, right? Because we're trying to get a sense of, for whom is this sample representative?
Right. You could imagine immigrants or some other, right?
Yes. Yeah. So once you screen on eligibility, there doesn't seem to be noticeable differences across the two groups. When you look at age, education, income, race, English as a second language, et cetera. There isn't anything in particular that jumps out and says this group is different. So we do think that we're it's representative of people who are faced with a transitory shock and are seeking assistance from local charities, which is millions of individuals across the country. Now, we probably should also say, and are interested in involved in taking up a more intensive program. Why people don't take it up that's actually a really big question. I mean, I think there's two components to it. One is that it's a pretty involved, intensive program, and so when presented to them and told, you will be expected to meet with your case manager, on a weekly basis, and they'll be meeting you at your house, and they'll be tracking progress. And some people just say that's not for me, right? And so that's probably a big chunk of it. But we know from other work that Leo's done and just interactions broadly with social service providers that lack of take-up is commonplace, even when the incentives to take up are quite strong. So even if you were to say something like, if you meet with a case manager 2 to 3 times, we will provide you with 1 month's rent. It's just a condition, is it? That an unusually high percentage of people never follow through with that. And I think that's actually an area. It's an area that service providers are really interested in understanding more. Why don't people follow through and take up services? And it's an area where I think we understand very little. So it's something that Leo is looking to explore more about in the future.
That's great. And one more related question from Liz Duffy. Did the screening eligibility ask whether the household was already receiving other kinds of support or case management? So sort of implicit is maybe they're not taking up this because they're getting this type of support from other places, but just needed that rent check or something.
Yeah, so they do a very general, what other services are you receiving? But we wouldn't know more details about that except until they say, yes, I want to be part of the study. Because once they say they're part of the study, then we give them a much bigger survey. We can get more detailed information on that. But they do seem to be, in general, getting similar levels of assistance. Like the fraction that say yes to that, whether they say yes to participate or not, is comparable across these groups. And through the surveys, we try to track that information for treatment and control after they agree to be part of the study. So speaking of the surveys, and here I will plug the University of Wisconsin Survey Center, because we used them to administer the surveys, both at baseline, when the client said yes to participate in the study, they got on a call with somebody from the Wisconsin Survey Center who administered about an hour-long survey that collected a wealth of information about their current situation and economic conditions, and all the subsequent outcomes that we got baseline measures for all the outcomes that we measured later on. And then the Survey Center followed up in the 1-year and 2-year surveys. They actually administer these surveys in person. So they went down to to the Fort Worth area, tracked individuals down, and we got 80% response rates, which for this population is really quite remarkable. Doing surveys like this, they're very, very comprehensive, are not cheap by any means, but if you're going to do it, I couldn't recommend more strongly the Survey Center in Wisconsin. They do great work.
We love to hear that. Thanks, Tim.
We're a repeat customer. We've used them for other projects as well. So what do we collect in the surveys? Most of the questions in terms of the outcomes fall into what we think of as 6 domains that we were interested in measuring. And the first 3 of these align very nicely with the program goals for the intervention. So we're going to measure labor market outcomes. The program was designed to increase savings and reduce debt, so we want to measure that, reduce dependence on government programs. But also just in talking with the case management team, we realized that there were some other outcomes that we should probably also look at. So these domains really were emphasized by the implementers of the program. So much time and effort is placed on working on budgeting and thinking more carefully about how they spend their money. It's interesting, they do this diagnostic where they say, what are your highest priorities in terms of things you want to spend, allocate your income towards? And then they ask, then they say, let's do a budget and see how you allocate your income. And they simply point out to them that they don't align up, that they're not spending money on their highest priorities. And exercises like that and work on budgeting seems to be a really important component. So we look at spending, we look at housing because that's a big issue that many of them face, and health as well, both healthcare usage, mental health, physical health, and self-reported health. So those are general outcomes. Let me give you just some descriptive statistics about how the intervention works. So in participation. So of those that were assigned to the treatment group, 91% actually followed through with the original assessment, which is like a 6-hour series of meetings that where they come up with the action plan that they're going to act on. The average participation length in terms of months was about 17, but there was a wide distribution. I'll show you a little bit more about that. Many, but not all, received financial assistance, and many multiple times. The typical issue where financial assistance was used amounted to about $225, a little more on that financial assistance. If you just look at conditional on take-up of the program, total cash assistance over the entire time that you're in the program, the median person received about $2,000. So think about $2,000 over the course of 17 months is probably a good way to think about it. There was also in-kind assistance. Some of them needed computers. There were a lot of in-kind donations to the charity, and they were allocated to the clients. Those were much less substantial. The engagement of case management was really quite substantial for those that were in the program. The median client received had about over 60 in-person or phone interactions with their case manager, and you can see that people stayed in the program for quite a while. So I said 17 months on average. If you look at after about a year, so this is the share that have exited the program. After about a year, 40% have exited the program. After 2 years, about 58% have exited the program. So some have stayed in the program for quite a while. Everything I'm going to show you is think about the impact after two years after assignment to treatment or control. Some people drop out of the program or complete the program well before that. Some will stay on afterwards, but we're going to measure things at most of what I'm going to show you is after 2 years. If you look at the program intensity over time, and these numbers are, this is the number of meetings by month, and this is conditional on still being in the program. So each month we throw out the people that drop out. As if you're in the program, how often are you meeting with your case manager? And what you see is very intense interaction early on. This is when the screening and assessment of the program is assessment of needs and laying out the individualized plan is occurring. And there really are, you still, even when you're about 6 months out, they're still meeting almost on a weekly basis. Over time, that starts to taper off quite a bit. But this is, the key point here is that there's a fairly intensive intervention with direct. It's not, this isn't email correspondence. There's direct correspondence between the case manager and the client. Looking at what they're doing when they have case management, we see that there's case management in general. There's a big chunk of it that's the initial assessments, so that's because it's so timely. About 10% of case management time is initial assessments, but there's also a big chunk of it that in routine meetings, which here you want to think about, this is where a lot of the coaching and mentoring takes place. There's a lot of emphasis on developing trust between the provider, or the case managers and the clients, and that trust is key to really diagnosing the barriers to self-sufficiency and what the solutions to or how you might address those barriers. They also spend a fair amount of time coordinating services. So how to, referring individuals to services throughout the community, or even services that Catholic Charities Fort Worth is providing. When thinking about financial assistance, for what issues is financial assistance used? The largest category, about a third of it, is used to pay for rent. We also see transportation plays a big role, but really there's a wide variety of issues that arise or needs that the financial assistance component will help address.
Jim,
let me just give you
another question from Lois Miller, one of our great GRFs. Is there any way that participants can be kicked out of the program, or do they always leave voluntarily?
It's pretty hard to get kicked out. But what happens is the clients go dark and then they close the case. So the client stops meeting with the case manager, and they have a procedure in place where a specific number of follow-ups over an extended period of time, which exceeds like a month. If the client is not responding, then they have a formal case closing procedure that they follow, so that they're not just tagging along with no services whatsoever. So I want to give you a sense of who is being served and their economic circumstances. So let me talk a little bit about that. So the one thing that kind of jumps out at you is that single moms are disproportionately represented in this. Remember how we're getting this sample. These are people coming into a charity seeking or calling a charity seeking financial assistance. Single moms are disproportionately represented amongst that group, so it's not surprising. But we do have married couples, but there are many of the clients have children, as you can see from the household size. There aren't nearly as many single individuals. Blacks in particular are overrepresented, but there's also a strong Hispanic population represented as well. They are predominantly low educated, but I think it's worth noting that 20% of them have a college degree. So this is not exclusively, say, high school dropouts, for example. Employment rates are low, earnings are quite low. That income with transfers puts them at about 60% of the poverty line on average at baseline. So these are very low income families. But it's not just that they're low income, and so keep in mind who they're serving. These are low income families that are in at least a short-term crisis, because the reason they're interacting with Catholic Charities is that they're seeking emergency financial assistance or other services. So when you look at kind of some other characteristics, it becomes very clear that this might be one unique aspect of this group is that they're facing crisis. So they don't have a lot of assets. Many of them are looking for work. Many of them are non-trivial fraction are using payday loans. But in particular, if you look at the hardships, right, 60% have experienced or are worried about experiencing a utilities disconnection. And that's a really large fraction as compared to, like, if you were to look at compared to the poor overall, but that's because of the nature of who we're recruiting. So this really is a sample that has experienced perhaps a short term, maybe a permanent shock, and they're seeking assistance to address that shock. So it's helpful to keep that in mind. I'll show you some data consistent with that in a minute. Because it's an RCT, we're keeping the econometrics simple. All the results that I'll show you in terms of the impact of the program, we're just regressing outcomes on a treatment dummy. We're going to absorb some residual variation by controlling for observable characteristics as well as the baseline measures of the outcomes, but in controlling for those things doesn't really affect our results, and also doesn't affect our precision too much. It's worth noting that everything I'm going to show you is intent to treat. So I'm going to show you beta 1 from this regression. Keep in mind that 90% of those offered the program took it up. So if you wanted to get the treatment untreated, you could divide these intent to treat estimates by 0.9 to get our treatment untreated estimates.
Jim, one more question and one point of clarification.
Mm-hmm.
So Kurt Paulson would like to know whether whether the clients are receiving housing assistance, such as vouchers, so public housing assistance. And so you're thinking of the offer and take-up among those who said they wanted to do the program and then started participation, rather than the population that was offered the program, right? So that high take-up is, because obviously there wasn't high take-up if you think of it as anyone who was offered the program.
Yeah. So
just clarifying.
So yeah, that this is an important clarification. So when you do impact evaluations, you're only using the people that were randomized, right? Mm-hmm. So there is the offer to participate in the study, which is offered a probabilistic chance of getting the program. That we don't incorporate in this, right? Because they're not in our study at all. So when I say take up the program, it means that of those that were offered treatment, said, okay, you've been randomized to the treatment group, you're eligible to take up Padua. Only 90%, well, actually that's really high, 90% said yes. Maybe it's not so high given that we screened on them saying they were interested in it. But, as is often the case, people change their minds or other things happen and they decide they don't want to take it up. So that's what we mean by take up. And it's very standard in the RCT world to account for that. It helps us interpret the magnitude of that beta 1, right? This is really an issue if take up is low. That doesn't invalidate the identification strategy. If, say, only 10% took up, you could still do this. But you would want to know that in terms of interpreting the magnitude of beta 1. And so that when take-up is low, people often also report the treatment untreated. In this case, because take-up is high, we just stick to the intent to treat. Okay, so what am I going to show you? And then I'm going to spend the rest of the time talking about results. So I'm going to show you results for almost all of them. I'm going to show you is the 24-month. The first couple of slides I'll show you will be 12 months and 24 months. And the reason I do that is it helps you see this what is pretty clear in the data, this Ashenfelter dip, which is just this idea that we're getting people who are at a time of at least temporary crisis. And so mean reversion itself would suggest we're going to expect outcomes to improve for the control group. And you see that immediately in the data. So let me just jump right to that and show you. So this is the gold plot shows you the control group fraction that are currently employed at baseline, 12 months after enrollment and 24 months after enrollment. And so what jumps out at you is the significant improvement in the control group. And so if for Padua to show you, and that's not surprising given the Ashenfelter dip, right? That there's understood, you get somebody at a crisis, some of them are going to find a way to address it and improve even if they don't get Padua services. But the point is that what we're going to measure is the impact of Padua above and beyond the improvement you see in the control group. And that improvement in the control group was a 50% increase in the fraction employed. It's worth noting that this figure can be mind-blowing to the providers, because providers often they often make all their decisions based only on the people they serve. And they see improvements in the people they serve and say, we must be doing a good job, right? They don't typically think in terms of the counterfactual. And so the control group tells them what would have happened if they didn't provide services, and they realize, oh, like we could have had improvements for the people we serve, and maybe that doesn't mean the program worked. And that we often have sometimes difficult conversations with providers about just because the people you serve show improvements in outcomes doesn't mean that the program is working. But in this case, as you can see, and I'll show you point estimates with p-values in a minute, we're seeing the percent employed increasing even more for the treatment group. You see it in earnings as well. Let me just jump to showing you the point estimates in particular, and all of the results I'm going to show you are going to be in the following form. So let me walk you through the structure of this table, and then the rest of them hopefully will be quite clear. So what I'm going to do in the far left column, I'm just going to show you the list of outcomes, typically within a particular domain. So this is the labor market domain. What are the outcomes, say whether or not you're employed full time, what are your earnings? I'm going to show you the control group mean, so you get a sense of at one month or 1 year follow-up, or actually 2 year follow-up, what is the counterfactual? And then I'll give you the treatment effect, the intent to treat estimate, to show you the precision of that estimate, and then just put it in percentage terms, so none of you have to do any math at all. Just look at the magnitudes, both in levels and percentage terms. I'll report the outcomes as well as a standardized treatment effect, which this is just, we estimate the weighted average of the standardized treatment effect across all the outcomes within a domain. So we take the average of these treatment effects standardized by the standard deviation of the outcome for the control group, which is a standard thing to do. So think about this as kind of like an index of all of the outcomes combined together, and the units for that is going to be in standard deviation units. So these are kind of the structure of the results that I'm going to present. Let me first show you labor market outcomes for the full sample. So I showed you this in graph form. You saw this a minute ago. We see this 6 percentage point increase 2 years later in the probability of being employed at all for those in the treatment group relative to control, off a baseline of 62%. That is, p-value of 0.22. It's not very precisely estimated, but some evidence that we see increases in employment. If you look at employment full time, we really do see that there's a precise estimate. The effect is larger, getting people to work full time, and that was part of the design of the program, was to get more engagement into the labor market, so that so people not just to get them to work, but get them to work substantially, so that they can get above a living wage. So there we're finding a large, so 25% effect on employment full time, and statistically significant. We're seeing a consistent effect on earnings, consistent with that effect on employment, but it's harder to measure earnings precisely. So at least for the full treatment group, we don't see that as a precise effect. But when you standardize across these 3 outcomes, as well as several others that I report in what I think is table 3 of the paper, we see that the standardized treatment effect for labor market outcomes is an improvement of labor market outcomes by about 0.15 of a standard deviation, and that is statistically significant. I should say, when I calculate the standardized treatment effect, we re-sign everything so that positive is good and negative is bad. So that if you're wondering why, some of the signs will switch on you. I'll point those out later. We do a lot on heterogeneity of impacts. So let me stick to labor market outcomes and show you the different effect on labor market outcomes by whether or not they were employed at baseline. We cut the data a lot of different ways. This seems to be one of the more substantive ways that we cut the data. We did this. We literally just split the sample based on whether or not you're employed at baseline. We also did this using the commonly used Abity method, where we randomly select a subsample to predict, based on your baseline observables, whether or not you're likely to be employed in the follow-up surveys. and then split the sample that way based on the high predicted probability of being employed in the future and low predicted probability. Those results are very similar to these, so I'll just show you these here. If you look at, I divide this by not employed at baseline and employed by baseline. So starting with not employed at baseline, you see that for the control group 2 years later, half of them are working. There's this very large, certainly relative to other programs, and marginally significant effect for those not employed at baseline for whether or not you're employed. Actually, maybe I should reserve the very large effect for being employed full-time. But the effect for those that are employed at baseline, I mean, the point estimate's the wrong direction, wrong sign, and imprecisely estimated. We take this as there's very little evidence that the program is improving employment for those that were employed when they came into the program. Now, Padua was designed to take individuals and families like that and move them into better employment, in other words, increase their earnings or help them increase their stability of their work. It seems that it's just more effective for those that are looking for employment initially than that. If you look at the different outcome of whether or not you're employed full-time, this is one of the larger effects that we're finding here. This is, a 67% increase in the likelihood that you're employed full-time as compared to the control group. So this is a very large treatment effect. If you're not employed, you're at baseline, you're likely to be more likely to be employed full-time. And we don't find that effect again if you were employed at baseline. So it seems, if you think about targeting of the program, targeting it towards those that were not employed initially seems to be particularly beneficial. When we look at other labor market outcomes for the same split, if you look at earnings, you get a very similar story. We're seeing increases in earnings for those not employed. Now, this effect is statistically significant and no effect on earnings for those that are employed. If you look at the standardized treatment effect across all the labor market outcomes, we find those not employed a very large, so it's a quarter of a standard deviation increase in improvement in labor market outcomes, and that's precisely estimated with no effect for those that are employed at baseline. Now, I think one of the important findings from this evaluation really benefited from our partnership with the provider and feedback from the provider about the nature of the intervention that helped us better understand how we should assess its impact. And one of the things that was explained to us in the way this intervention works is the very different paths that different clients will face. And this is really important for understanding the overall impact and why we might not be finding impacts in other areas. So I didn't show you that there's a decline in the participation in government programs, but the decline is small and not statistically significant. So why might that be the case? So I think it's important to understand these different paths. So when individuals and families enter the Padua program, you could generalize that they take one of two paths. First, there are families that are in severe crisis. So it's not just that they lost their job. They've been evicted from their house and they are living on the streets, right? So these are the first order issue is that they're homeless. For those families, they don't say, now how can we get you a job? Let's work on getting you some education. The first thing they do is stabilize the family unit. And so they work on stable housing. They work on, if it's a drug addiction, they work on addressing that first so that they can get them to employment. And so oftentimes it's not till later on that if they ever get to it, to working on job market skills. Now that's very different from a family not in severe crisis. So maybe it is still a significant crisis, but not one as anywhere near as being homeless. For that group where if the issue is really, the barrier is to self-sufficiency is significant labor market or lack of significant labor market attachment, they immediately work on the job market skills. Like what do we do is it get them into an academic program, get them into to give them some job training, networking, et cetera. They work on those. And so it's reasonable to expect that outcomes would be very different for these two groups, particularly whether or not we would find effects on labor market outcomes and participation in government programs. So that motivates one of the splits that we highlight in the paper in particular, which is kind of thinking about separating the sample along the lines of these two different paths. And so we do so by separating them into the group that is unstably housed. So think about this as those literally homeless, or they're living with others because they can't afford to live on their own. And then the other group are those that are actually renters or homeowners. And we're going to look at all the outcomes separately for these two groups. And so let me start with those that are stably housed. And I'm sorry, I'm going to look at both those that are stably housed and unstably housed. But the first outcome I want to look at is whether or not in the future, 2 years later, you are stably housed. And this is just to point out that they are in fact doing, the intervention is actually doing what it's designed to do for the unstably housed. So if you look at this group and you look at the fraction of the control group that was initially homeless, think of it that way, at baseline, 56% of them are owning or renting by the time 2 years later. But there's a 60% increase in the likelihood that you're owning or renting if you were unstably housed at baseline and you were part of PADUA. And that's a very statistically significant effect. So PADUA is clearly having a large impact on the likelihood that you are stably housed. They're addressing that immediate need first. And part of what that means is, back to this question that I don't think I ever answered, was do we observe housing assistance? We do observe whether or not they receive housing assistance. Part of serving those that are unstably housed is getting them access to housing assistance, whether it's the federal government or other charities that are providing that kind of assistance, and getting them on other government programs like SNAP and TANF. So there's a reason why we might not expect participation in government programs to fall, particularly for some subgroups. If you look at the stably housed, not surprising, there's no effect of PADUA on the likelihood that you are stably housed in the future. This group was already stably housed. It's not, the intervention wasn't designed to improve that outcome further. So that's just the effect on housing stability. That might help you understand what's happening in terms of the labor market across these two groups. So let's just look at whether or not you're employed. If you focus on the unstably housed, remember, we're not going to immediately address the barriers to employment for this group. We see little to no, actually this is the wrong sign, effect of PADUA on employment for this group. But if you look at those that are stably housed, we see a sizable and marginally significant effect on employment. If you look at earnings for this group, so kind of consistent with whether or not they're employed, again, no effect on earnings is the wrong sign, and this sizable positive effect, marginally significant effect for those that are stably housed. And here, I think another way to see the differences across these groups is to look at the outcomes on government programs. If you look at whether or not they participate in any government program, this is SNAP, TANF, it includes UI, WIC, et cetera. What we see is that those unstably housed, actually the point estimate suggests they're more likely to participate in government programs, although it's not precisely estimated. When you look at those that are stably housed, they're much less likely, and now it's marginally significant. And we do have to acknowledge that when we start splitting these samples, the sample sizes get a bit small, and so getting precision can be tough. If you look at the standardized treatment effect, though, you're seeing, and here, here's where we flip the sign, where all the positives are your reduced dependence on government programs or participation in government programs. The unstably housed, the negative sign suggests that there are increased use of government programs. The stably housed is more than a tenth of a standard deviation decrease in use of or participation in government programs, and that is statistically significant. There are many outcomes that we could go through, but I want to leave time for Q&A. So I'm going to just give you a highlight reel of some other outcomes, and then I'll make a comment on cost benefit and turn it over to you all. So health outcomes in particular were interesting because one of the findings that we found consistent across really all cuts of the data across many different subgroups was that they report an improvement in self-reported health. So SRH, self-reported health, improved. That is a large effect that's fairly, that is also statistically significant. It doesn't look like it's because they have greater access to health insurance. It doesn't look like it's because they're more likely to visit the doctor. From the best that we can tell, there's some suggestive evidence that people are feeling healthier, particularly on the mental health side. And perhaps not surprising that they're engaging with somebody who's providing mentoring and coaching services, that they feel better about themselves and more comfortable about where they are, their current situation, and that leads to increases in mental health. Some evidence they're less likely to experience medical hardship, but not precisely estimated. And the positive here in the standardized treatment effect means better is improvements in these outcomes, and that's marginally significant. So some promising evidence there on health, highlighting just a last few outcomes to help understand the nature of the intervention. I mentioned the emphasis on budgeting. Many of those in the treatment group are much more likely to report using a budget. So that is actually happening and actually sticking. They continue to use a budget even after they're done. This just speaks to the housing stability. They're less likely to be not contributing to their rent, so they're more likely to be paying rents. They more like one. I didn't show you results on savings and borrowing. We found very little effect on savings and borrowing of note. But one thing to note is an increase in whether or not likelihood that you have a retirement account. And this is consistent with what we're finding on the labor market outcomes. So they're more likely to have jobs, or more likely to have access to these kinds of 401k plans, for example. Also, I mentioned that they provide services for those who are undocumented. The likelihood that you're undocumented declines, and that's statistically significant if you're part of the PADGWA program. So this is one potential mechanism, although too small to likely explain the bulk of our positive impacts on labor market outcomes. So in terms of costs, because that already came up, just to kind of a quick summary of that, it's about PADGWA is about $10,000 per family per year. When you look at that relative to the increase in earnings we see for our full sample, you can just do the calculation of how many years of increased earnings would you have to have before it would pay for the cost of the program. That's close to 8 years, which seems quite high. But if you look at it for some of the subgroups where there are clearly higher returns, for example, the stably housed, it's down to 4 years. It's similarly about 4 years for those that are employed at baseline. But it's also worth noting that there are many returns besides just increases in employment. So we're seeing, particularly for some subgroups, reduced receipt of government programs, but also other benefits that we aren't necessarily measuring right now, like participation, like say involvement in the criminal justice system, or actual involvement in hospitalizations and the like. Just wrapping up, reminding you what we said, what I've said already, that there's strong evidence that PADGWA has its intended effect on employment, use of budget, legal status, housing outcomes, health, etc. There's less evidence, and I didn't show you all of these, but there's less evidence for the full sample that it reduces government participation in government programs, but some evidence that it does for subgroups. I didn't show you the results on where most of the impacts were very statistically insignificant, were suggestive of little impact. Not a lot of effect on consumption. We think that there's income has gone up, people are spending more, they're using budgets, they're spending less, is a little bit of an offset there, and little effect on savings and debts. Where we're, and this, my last slide is just to give you a sense of where we're going there, is we're going to link these participants to administrative data to track earnings over a long period of time and to track participation in government programs. we need this effect to be, I mean, 2 years is a long time for a program to have a sustained effect, but I think for it to be cost effective, it really needs to be, we need to demonstrate that it persists. We are exploring replication of this program and whether or not we can reduce costs, having larger caseloads, et cetera, whether or not there's additional evidence of targeting this program can increase impacts, say, for example, those who are employed at baseline. And we're considering interventions at Leo where you implement something like Padua for particularly vulnerable groups like those exiting prison or refugees. But let me stop there and see what questions I can answer.
Thanks, Jim. And we have a couple queued up, so I'll start with those, but please, folks, go ahead and type into the chat or tell me that you want me to unmute you so that I can do so. So the first one, which actually was typed in a little bit earlier, but I thought it was worth saving to the end. Mallory says, it seems like the problem statement here is understandably focused on the individual level complexity of poverty. However, I could imagine arguing that even a wraparound intervention is a Band-Aid solution to systematic community and population level disinvestment, discrimination, etc. To what extent do these larger systematic contexts of poverty influence your study?
So the direct influence on the study is they provide the context within which we are implementing this study. And it is absolutely the case and important to point out that this intervention, can't be by itself the solution because it's working against all of those challenges in the system, right? So that we can address all those barriers, but a case manager is not going to, solve discrimination problems, right? And nor is it going to solve problems like, lack of labor demand, right? So there might be macroeconomic issues that are beyond the design of this program. But I do think that there is some hope here that it could be scaled up to a much larger degree, where it starts to crowd out those things. So the extent that case managers might not be able to solve structural discrimination, but it might actually help more individuals address that discrimination on a wide scale. So that's just a different barrier. The fundamental cause might be that there's discrimination, but what do we do given that we might not be able to change that in the short run? What can we do? Well, we're going to help you obtain skills where the discrimination is not going to be as big of a factor. Maybe they're discriminating against you because you're a refugee. We're going to allocate you to a network that we're aware of that where that barrier is not going to be as significant. But I do think it's important to point out that this program is not, because it's so comprehensive in nature and it's touted as being able to address all different problems. It's not the solution in and of itself because of these other structural problems.
And I want to jump in, but we have questions queued up. So I'll simply say, I think it would be also, for the context, knowing how much the case management runs interference, right? So in just the way you suggested, right? Because that the ability to not just like refer someone to something, but have a network that will serve them could be really important because of the experiences of discrimination and mistreatment and all of that. But we have a queue of questions. So coming from Tim's meeting, there's several. First,
hey, Tim.
I feel like I should. Tim,
muting Tim's meeting. That's something I haven't seen before.
I'm going to unmute Tim and if he wants to jump in. His first question was whether he can have the paper. Because yes. He feels like it might be generalizable. If it to the extent that it's generalizable, it could be scaled up. But he's also interested in impacts on child outcomes. Tim, do you want to say anything, or should I just keep reading?
That's thanks for the thing about scaling up, Jim. And I really think Catherine's points in the MTO assistance programs that Larry Katz, everybody talks about, having an intermediary who can help ease them into housing and talk to the landlord seems to have made a big difference. This might be the same way, and I like that. But my main question was, are there any positive effects on child outcomes as well? I understand if you look at the tight economics of it, fine. great, but we all know that there's much bigger outcomes, and I'm very interested in what you're seeing. And I also have a student who's working on homelessness, and so when I read the paper, the idea of stabilizing housing first and then employment makes a lot of sense. But pick any of them. Thank you.
Yeah, so since Catherine brought it up and you mentioned it as well, this idea of being the intermediary, I think is really important for replication and scale, because one of the things, if you were to criticize the generalizability of what we're doing, is one of the things we might have done is found a really good social service agency. And they are well connected. We know for a fact they're very well respected in the community. They're viewed as the best in the business. And they have those strong networks. So they when they launched this program, they built connections with all the other social service providers in the community and said, "Will you help us? We're going to refer clients to you." And they set up that network. And so it's a real question: is can you replicate that? Because you need somebody that's can be an intermediary for you. It's not just providing one-on-one services. And so I think that's really important. And we're going to test this. We're going to test it in other communities and other contexts, and I think we'll learn a lot more about that. Tim, your point about child outcomes is a really good one. And at some point we had to make hard decisions about what outcomes we were or were not going to measure at least at this point. So what we did, we did not measure child outcomes specific to the child. We did get the consent forms are structured such that in the future we hope to get access to administrative data and maybe even link those children to academic outcomes like educational attainment. And in the long run, we'd love to do what MTO does. We'll book it for 20 years from now, and I'll tell you what the earnings of these kids are in the long run. But it's definitely something that we're interested in.
Just going back to the first part of that conversation or question, Mike Collins is wondering if there's heterogeneity that, he didn't say it this way, but I will. Is there heterogeneity that can be used to understand how important the caseworker or coach is, right? So some coaches are probably better than others. Can you leverage that in some way to learn how generalizable or how important that is? Sorry if I bastardized your question, Mike. But.
Yeah, it's a really important question. We would love to randomly assign, we proposed it to randomly assign the clients to the case managers. And the challenge there was that they had to manage the capacity, in particular the capacity for the case management teams that had Spanish-speaking case managers. And so that it just became too cumbersome that we weren't able to do it. It's something that we would like to consider, or we are going to consider as we do follow-up studies and replicate this. What I know that Catholic Charities Fort Worth would say here is that they put a lot of effort into the training up front and documenting exactly what the skill set is to try and prevent it from being a particular person who's good at this versus a program that is well structured and it's easy or at least feasible to implement on a consistent basis. So they have tried to address that. Testing that I think would be super interesting to do. We haven't done it yet.
Okay, and I will give the last question to Kurt Paulson, who says the $10K per family per year program costs. How much is direct money to the families and indirect benefits, and how much is staff costs, obviously the case managers, and program overhead? He says, I guess in terms of cost effectiveness, would it be, so this is a question, would it be more effective to give people that cash and benefits without the intrusive paternalistic case management?
Yes, interesting, and I welcome the kind of provocative way of calling it paternalistic, because I think let's call it what it is, which is that this program is a bit paternalistic, and that is a fundamental economic question. Should we just give them emergency financial assistance? Now, the nature of the program, the motivation of the whole motivation of the design is that would be less effective. It's on the near the top of my priority list to be able to answer this question, because I think it digs down. Well, it speaks to whether or not we should scale this program. I think the answer is that it is too expensive for some groups and it's not for others. And that speaks to the critical importance of targeting it to the groups that are going to benefit the most. And why do I think that? Well, I don't have great evidence on just giving cash assistance on the order of what they're giving, which I should answer your first question, which is about, think of it as about $2,500 over the course of 2 years. And so when you combine the cash assistance and other assistance. So the bulk of the cost is the case management. In another context, Catholic Charities did an intervention of a comprehensive case management program in a community college that was designed to help community college students actually obtain their degree. And there they had an emergency financial assistance component. And we had a second treatment arm where they just got the money. And in that case, in that very special context, the money wasn't enough. We saw much greater, better outcomes for those that provide for those that got access to the comprehensive intervention than those who just got the resources. But we need to understand this in the broader context. And I will say that when talking to providers broadly about this idea of paternalism, many of them will say that the complicated nature of the situations that the families are in suggest that it's going to be really difficult for them to do it on their own. And so this is Catholic Charities Fort Worth is by no means unique in saying they want a more comprehensive program. That is perhaps one of the most common stories we hear from providers right now. When we say, what are you doing that's innovative? They all say, well, we're trying to design these much more comprehensive programs that address all the challenges. So I think there is broad recognition of that. Which is the best strategy once you incorporate costs and benefits? I think we're looking forward to do more research to answer that question.
We are 2 minutes over. If you have 1 minute more, can I ask one more question?
Sure.
Acknowledging that people will start hopping off because they're off to their other things. I'm curious if you had direct measures of mental health.
We didn't do the standard depression diagnostic, the short 7 question. Yep. We have some questions that were designed to measure self-efficacy. Mm-hmm. And there was some indication there that there was improvement, but it was, I would call it suggestive, right? It just wasn't precise enough. So the mental health, I'm really, some of the qualitative data that we have in the study and feedback we're getting from Catholic Charities Fort Worth is really what points me to that. But I don't have concrete evidence. We'd love to add the right diagnostic to future surveys.
Yeah, and there might be, I'm asking about this just in the context of our unconditional cash gift study. So we're finding some, anyway, we have some stuff. We're thinking a lot about mental health is probably the best way that I can put it. But I think there's also a distinction between that agency and problem solving, like those types of things versus straight up mental health, more like depression, right? And so I could particularly imagine, reducing undocumented status as just being a tremendous sort of stress, agency, hope generator. So it's interested in what you find, but we'll bring you back in at least 5 years to find out what the follow-up is. We won't wait 20. We are not going to wait 20 to find out.
Yes, would love to.
Jim, thank you so much for your time. I know I enjoyed it. I know everyone else did as well. So when the pandemic ends, we'll have you back. You can enjoy a better fall day than we're having here. It's pouring and cold. So.
Great. I really enjoyed it. And I forgot to mention that Tim's question, I will send the paper to you and you can make it available.
One of our affiliates, go ahead and send it. I will say one of our more technologically advanced affiliates posted a link to it. So
perfect. It's on my website.
Assuming Tim can navigate that. It's been circulated already.
All right. Problem solved.
Thanks. Thanks,
Thanks
Jim.
so much.
Bye.
Take care.